Well, good afternoon, everyone, and I hope that you had an enjoyable lunch, and or you're currently enjoying your lunch and settling in. So, my name is Amin. I'm from Group Clinical Education at NHG, and welcome to this year's first Humanity at the Heart of Healthcare seminar that is proudly brought to you by NHG's Humanistic Medicine Institute. So, since its conception, the aim of the H3 seminar series has always been to bridge clinical excellence with perspectives from social sciences, the humanities, and health professions education. So, our hope is that these seminars serve as a reminder to all of us in the caring professions that beyond our roles and our duties, it is our shared humanity that truly lies at this very heart of healthcare. So today we are diving into an area that is, I would say, kind of unapologetic in highlighting our inherent human limitations. So just looking at the numbers in attendance today and the growing number of you coming in, it is clear that this topic holds a deep significance for everyone here who's in the caring profession. So from my PhD research on spiritual interventions for healthcare, I personally find this topic to kind of like, how should I say, reinforce this epistemology that the human spirit is one that is inescapably linked to the identities we form for ourselves as professionals, with our families and people that we know. So it kind of persists in everything that we do and believe, and in every aspect of our interactions. So to tell us more about this very important intersection, it is my privilege and honor to welcome Professor Lalit Krishna, who is a senior consultant at the Division of Supportive and Palliative Care of the National Cancer Center. He holds faculty appointments with the Center for Biomedical Ethics, Duke NUS Medical School, and the Yong Lulin School of Medicine. Not only that, Lalit is also a distinguished scholar, recognized for his extensive contributions and publications in the areas of professional identity formation, best interest determination, the cost of caring, like today's topic, and this is just to name a few. We are also joined by a familiar face, our very own Dr. Aaron Ang, who is a senior consultant at the Department of Psychiatry of Tan Tock Seng Hospital and the director of NHG's Humanistic Medicine Institute. Aaron's expertise in clinical ethics, shared decision making, and his role as a psychiatrist with special interest in holistic well-being are especially pertinent for today's topic. So before we begin, just some housekeeping matters. So firstly, you need to know this webinar is being recorded. Next, we will be also using the Zoom Q&A function for your questions and comments. So Lalit, Aaron, and I will be fielding your questions and comments at the end of the webinar, and we'll have about 15 minutes to do that. So we urge everyone to stay till the end, give us your feedback, let us know your questions, and we will have a full-on discussion about that. So without further ado, please join me in giving a warm welcome to Lalit.
Thank you. Um, Thank you, Amin, and thank you, everyone. I think I will start with an explanation. Have you noticed that everyone's got a background on Hume? Mine is a picture. And let me tell you a little bit about the picture, and it might tell you a little bit about what I'm going to talk to you about. So I did my training in the UK, and one of the hardest things that I did was working in a palliative care unit, which looked after kids. And the part that I struggled most was, what do you tell a mother or father uh, when their child is about to die and there's really nothing more you could do? It's something I struggled with, and it really left a mark. The picture you have behind me is a picture of a house which my father bought for me just after I finished this part of my training. It reminded him of his house in Taiping in Malaysia, and the reason why he bought it was, if you can focus on it, there's a picture of a window and a dove flying out, and he said, "There is hope. from every bad experience, there is hope and there's something to learn. And that has sort of inspired me to do quite a lot of my work. And what I want to talk to you today is about that cost of caring, the caring for a patient at the end of life and the impact on the physician, and then moving on to everybody else in the healthcare profession. So I'm going to quickly share my slides. I apologize because I tend to screw this up a lot. Can everyone see my slides? So the slide that you should be seeing is a picture which is also something that my dad bought for me. And as you go along, you will see a little bit more of the picture. It's actually a face, and there's water dropping. And if you look at it, it's actually sometimes looks like tears, and sometimes it's just sweat, and sometimes it's just raindrops on a window. And again, it's part of how I look at my job, and I will talk to you a little bit about this. So I want to talk to you a little bit about the cost of caring. And so what is the cost of caring? So here's a problem that we face as professionals. I did a little straw poll over the last few weeks. As healthcare professionals, we face moral distress. One of my colleagues recorded over a space of 1 week, he dealt with about 12 to 15 situations where he felt moral distress. Moral distress is the sense that your belief system is being in conflict with the situation you might be in. This definition is very different from the definitions that we have from Western philosophy, which actually says that moral distress is feeling not being able to do something that you know is morally right simply because of the situation. In Southeast Asia, that isn't the case. In Southeast Asia, the situation is much more social-culturally sensitive. It's about not being able to do the things that you believe is right. It's your values, your principles, your belief system. And the impact of repeated moral distress is something that we're going to talk about. So I'm going to talk to you about the cost of caring. What is the cost of caring? The cost of caring is a mixture of moral distress, not being able to do the things that, or conflicts between you and your belief system. It's compassion fatigue. It's the cost of looking after people, your patients, their families, your colleagues, and sometimes even visitors to the patient. It causes emotional and very often physical fatigue. Increasingly, our data also suggests it causes you to question your spiritual beliefs. In addition, our physicians and specifically our nurses deal with something called vicarious trauma or secondary traumatic stress. They deal with and take upon them the suffering of others. They watch patients suffer. They watch their loved ones suffer along with the patients. It's hard not to be affected by that. Finally, we'll deal with burnout. The cost of caring is all of these things. And what we've done in our group, which involves National Cancer Center and mostly Sing Health, but increasingly some work with NUH and quite a few students from LKC as well, is that we've done systematic reviews and done interviews now with patients, doctors, nurses, to find out what the effects are. I'm going to give you some of the quotes from doctors and nurses. So what is moral distress? This is a quote from one of my colleagues. She says, basically, it's draining. It was mentally and physically draining. If I go on vacation, my phone is on all the time because I'm texting the teams. I feel compelled. I'm on vacation, but I feel compelled to answer them. The moral distress isn't here just the fact that there was competition between her moral values. It's also about her self-care. It's also about balancing between looking after herself and looking after her patients. And then, of course, there's a part that remains hidden, which is how does she look after her family when she's not fully there all the time? And this is a common theme that we see especially amongst nurses. We see compassion fatigue. Again, it's that draining sensation. The point about it here is that the moral distress here, there's another quote that I want to give you is, I don't know whether I'm doing the right thing for the patient. I don't know whether or not the decision I make is the best for him. I grapple with it at night. I grapple with it in the day. And no one can give me an answer. And sometimes I don't know who to talk to. This is just a tip of the iceberg. We have physicians dealing with supporting patients, supporting their families, supporting their colleagues. And this is a quote from one of the palliative care physicians. It says, it's at 2 a.m. at night. They're texting you about them feeling tired, feeling alone, worried that they would die. It may be tough, it may be traumatic, but it is always emotional. Culminates in this. We need balance. We're under so much stress. The amount of work we have to do and juggle. Sometimes I feel like I throw in the towel. What is the implication? We know that the cost of caring is that you question your beliefs, you question who you are, you question your values, and all of these conflicts that you feel, they change the way you think about yourself, the way you see yourself, and the way you practice. Some of our data suggests that the impact on the individual, on the physician, on the nurse, on the social worker, is that it affects what makes them who they are, their personhood. It affects their social ring, their roles in society, their responsibilities, their role as a physician or healthcare professional. It affects their relationships with others. I'll give you an example. When we interviewed some of our nurses, well, some of them turned around and said, I used to come home and talk about it with my family. But I stopped now because what it did was it made them upset. It made them sad, so I stopped. Sometimes I'm sad and I don't want to show it, so I push them away. I have a colleague of mine who told me that when she comes home, the first thing she does is not go into the house. She sits in her car and just decompresses. Sometimes she cries. She believes that this is part of the reason why the stress has affected her relationship with her spouse. For some of our staff, we've noticed that it's hard concentrating. It's hard being who they were. Our data, and this is from systematic reviews from around the world, suggests that if we aren't careful, healthcare professionals become very cynical. They lose their empathy. They don't connect with their patients. There is poor patient experiences, poor family experiences, poor familial support, poor patient support. And here's the thing, there's also poor interprofessional working, culminating in compromise of the patient safety. This is a big problem, and one that actually became very obvious during COVID. Much of the work that we've done actually started from COVID work. And one of the papers that we wrote on was actually looking through the social media posts of doctors during the COVID, and it showed the stressors that they were going through. Those stressors have come down significantly. But the COVID lens has allowed us to see what could be if we don't address things now. Another part that we have failed to address is the innate part of who you are, your religious beliefs. I get asked, what's the one thing that you don't want to do? And I quite frankly say, I don't want to do pediatric PAL, and I'll tell you why. So I looked after a child. He was about 10 years old. And this was the time when I was in the UK and Teletubbies was still on. And my name is Lalit, so my patients used to call me Dr. Lala. And this kid, he's a hardcore Liverpool fan, and Liverpool jerseys and everything else, and so I really liked him. And he was in pain when we struggled. My consultant struggled. I was an MO, I think, at the time. And I remember 2 days before he passed away, it was very early in the morning, and he was awake, and I walked in and he said, Dr. Lala, when's the pain going to stop? The impact was huge. I spoke to my consultant. We tried to do a whole lot of things. We failed. In the end, he passed away. He did pass away reasonably comfortably. But I found myself questioning everything. I questioned my beliefs, I questioned my values, but more importantly, I questioned my religious beliefs. And it's been a long road back. So I want to ask you, who cares for the carer? So we moved on, and one of the major projects that we've done is actually trying to address this. We found that there are 3 ways we can do that. Organizations need to take their responsibility. And one part of it is this. So I talked to you just now about the ring theory, the 4 circles just now. And we can adapt that to a tool and use that to assess our staff over time and see how they're doing. And when we find that they're struggling, we support them. What we found is, and these are from a series of systematic reviews and then follow-up papers, is that if you give people guided reflections, regular meetups, peer support, group support, they do better. One of the things that I want to do with my team is a mentor program. It's going to be named after my mentor, Prof Cynthia Goh. It's a Cynthia Goh mentoring program that I'm planning to set up, where we will have senior doctors mentoring senior doctors, senior nurses mentoring everybody, social workers helping each other. You see, the thing about it is that the cost of caring isn't straight away when you see someone say, Dr. Lala, when is the pain going to go? The cost of caring comes when you're sitting quietly and watching the sky and and the kid's voice is in your head. Or when you see someone that reminds you of them, or even now when we talk about it. The cost of caring comes when you deal with difficult situations that maybe have echoes upon this. When those moments come, when you need your help, that's where your mentor comes in. Prof Go and I used to meet once a month. I have another mentor I meet maybe once a week. I'm a palliative care physician. I've done this job 28 years. I still need a mentor. I still need someone to talk to. And I think from my experience, that's something that I want to do and something I want to give back. Organization needs to also help with its culture. It needs to provide psychological support for those who need it in a timely manner. You see, there's nothing worse than being told, oh yeah, we can get you seen by X, Y, and Z, but it's in a week's time. I'm not saying you do it there and then, but give me help when I need it most. One of my colleagues called me over COVID, and she asked me, Prof, I don't know what to do. And I asked her why, and she said, I have one bed. I have a 16-year-old kid who's been on the bed, intubated now for 7 days and not making not much progress. And I've got an 18-year-old boy. What do I do? Because there's no one else I can take off the vent bed. Problem was that after talking to her and told her to try and get psychological support, in her country it was nearly impossible. The beauty about working in SingHealth and in Singapore for that matter is that I can get help. My staff are sorted. But what about the people who don't work with us? What about the people who don't know where to come to? The thing that I have to ask is, if not now, when? It's time we did something. So this talk, this fireside chat, if you like, is a call for action. And whilst we ask for organizations and teams to take in their responsibility, there's also some responsibility upon us. We need to self-care. We need to reflect, and we need to be able to ask for help. And for that to happen, we need to trust, we need to build relationships, and we need to know that it's okay to ask for help. I'm saying that the cost of caring is mounting. I'm saying the cost of caring is real, but I'm also saying that the cost of caring can be addressed. And I look forward to having a healthy conversation about this. I'm going to stop slides and ask Aaron to grill me, I suppose, and we'll look through some of the questions that you might have had. So I'll stop here. Thanks.